Hi, my name is Jacob Robinson, and I'm a third-year medical student at Lake Erie College of Osteopathic Medicine. I am going to be presenting a case of esophageal squamous papilloma today. I worked on this case with Robert Burke, a classmate of mine, and Dr. Michael Herman, a gastroenterologist. Esophageal squamous papillomas are rare benign tumors with a very low incidence in the general population. The majority are asymptomatic and just an incidental finding on EGD. The ones that are symptomatic, though, usually present with dysphagia that is refractory to medical treatment. In our case, we had a 42-year-old Caucasian female who was referred to us for acute on chronic dysphagia for 6 months. The patient had no history of food impactions or reflux disease. Her weight hadn't changed, and all labs that were performed were unremarkable. A barium esophagram was completed, and it was notable for a small hiatal hernia and some mild reflux in her lower esophagus. Nothing with her clinical history or other studies suggested achalasia or any other etiology. An upper endoscopy was performed, and a suspected ESP was found and biopsied. ESPs are characterized histologically by finger-like projections of hyperplastic squamous epithelium that covers connective tissue core. Neutrophil invasion of the lesions is usually present. Most cases of solitary ESP are asymptomatic, and the gold standard for diagnosis is biopsy. They are found most often in the middle to lower third of the esophagus. The classic patient is usually middle-aged with GERD. Being overweight, being a smoker, or having a hiatal hernia are additional risk factors. These risk factors also increase the risk for having GERD. The etiology is currently unclear, but the leading hypothesis is that chronic mucosal irritation from GERD spurs ESP development. Some have proposed that HPV infection could also play a role. However, most of the ESPs that have been tested have been negative for HPV. The ones that were positive, though, were found more often in the upper third of the esophagus. Treatment for ESP is usually only reserved for symptomatic cases because there is a low risk of malignancy in these solitary lesions. Several treatment options include snare polypectomy, cautery, biopsy forceps, radiofrequency ablation, and endoscopic mucosal resection. There is yet to be a report of recurrence following removal of the lesion. A small number of cases have developed into squamous cell carcinoma, though, if untreated. The rare patients with multiple lesions, which is also called esophageal squamous papillomatosis, should be treated with esophagectomy because these cases are associated with much higher rates of eventual malignancy. These lesions are extremely rare, with only approximately 12 cases reported in literature. Based on this case report, as well as reviewing the literature of previous cases, we advise ESP to be part of the differential diagnosis in a patient with either GERD or dysphagia that is refractory to medical treatment. Future research still needs to be done on the management of esophageal squamous papillomas due to the extremely low prevalence in the population and the uncertain clinico-pathological associations. We have included the references that we used to help us write this case report, and we would also like to thank Dr. Herman for his assistance in writing this case report. Thank you so much for listening to our presentation, and I hope you have a great day.